thanks for being here. Hopefully this is going to be informative for you. A lot of the things that we deal with, and in particular on the spine side of the practice, hopefully I'll be able to answer. Maybe there'll be some things you've heard before, or maybe we'll correct some things that you thought existed or how things work, and maybe it's a different way. So that being said, let me tell you a little bit about me. I'm one of the partners at Carolina Orthopaedics. My name is Dr. Stephen Parker. I'm originally from Columbia, South Carolina. I attended medical school at the Medical University of South Carolina in Charleston. From there, I went on to complete a residency at the University of Pittsburgh. And then from there, I did a fellowship in pain management, which brought me here. I actually moved here 8 years ago now from Charlotte, North Carolina. And since being here, we haven't looked back, and it's been a great move for both me and my family. So that being said, today we're going to talk about therapy options for the management of chronic pain. Hopefully at the end of the lecture, as I stated, you'll kind of understand some of the disease states that we are faced with, both in the neck, the thoracic spine, and the lumbar spine, and some of the approaches that we do today. All right, so once again, by the end of this conversation, you will know more about chronic pain, determine if there are other options to help manage your chronic pain more effectively, and discuss options specific for you during your next appointment should you choose to make one, or if you're thinking about something. Or one other little thing, I want to give a bit of gratitude and thanks to Boston Scientific. Boston Scientific is co-hosting this with us, and they provide a technology called the spinal cord stimulator, which we use in patients who've had surgeries to help with a pain phenomena that will often develop as a result of something we call post-laminectomy or failed back syndrome. And you'll hear a little bit more about that as time goes on. Next, pain is an electrical signal, as it states here, that travels along the spinal cord to the brain. So a lot of times my patients will hear me speak about the highway to the brain. A lot of technologies and a lot of things that we do in pain management is with that in mind, in that your periphery. So the nerve endings in your fingers and your arms through the shoulder go through the neck. The chest and the thoracic area runs through the thoracic spinal cord, and so from the waist down, those signals come from the feet, knees, legs, hips, through that area of the spinal cord, which ultimately travels to the brain. Everything finishes at the brain, and so your sensation or your perception of pain, hot, cold, things of that nature, has to run through the spinal cord to get to the brain in order for you to have that sensation. So any alteration anywhere along the highway, if you will, or that pathway can be problematic, but you'll hear more about that. So chronic pain, what is chronic pain? Chronic pain is having pain 3 to 6 months or longer. So if you've had surgery, let's say, and you're in pain for a couple of weeks, but then things are getting better, that's not really considered chronic pain. So a lot of my pain patients or chronic pain patients have been in pain for at least 3 to 6 months, if not years. And in those situations, especially in these days and time, we try to figure out either by way of procedure and or medication, if all else fails, what is the best therapeutic treatment for them. I'm sure most of you have heard a lot of the wranglings in the newspaper now about this opioid epidemic that we're facing right now. You know, probably 15 to 20 years ago, there was an edict that came down from the state medical boards across the country that actually complained that doctors were not adequately treating pain. And so they called their congressmen and their senators and they said, hey, listen, you got to do something about this. And so what happened was you could be sanctioned by the state board if a patient complained that you weren't giving them enough pain medicine. So what happened? The needle swung the complete opposite direction. And so then you could walk into your doctors. They were afraid to be sanctioned by their state medical boards. And so they started doling out the medicines like really, really heavily. So now what you have is a whole generation, if you will, of patients who are used to having 240 pills, 360 pills, 400 pills at a time to treat their pain, so to speak, and it has gotten out of control. And so what happens is, what has happened is physicians become a bit frightened by that. Number one, that burden of being a doctor who prescribes that much medicine. And so then you'll become a little uncomfortable as a practitioner, let's say, and you'll back off. And so patients who are used to having that, that's frightening. It's frightening mentally, and it's also frightening from the standpoint of your pain. And so what's happened is heroin has hit the streets now, and heroin is very, very cheap. So let's say I have a working age patient who's used to taking a whole bunch of medicine. They come in to see me and I say, hey, look, I'm sorry, can't do it anymore because we're under all this scrutiny and all these regulations now because kids are dying in Vermont and New Hampshire and Massachusetts. I mean, 10, 15, and 20 a month, okay? And so with that now, if you have a desire for the medicine and the physicians, because of all the different criteria and the scrutiny we're under, they back off, you're gonna get that medicine from somewhere. Those pills, as an example, and I'm just kind of adding this in because I want everybody to kind of understand what's going on, up to a $20 per pill street value from these kids. I mean, you know, they get the pills, they say they still steal them from their grandmother or friend or whatever, and they can go to school and sell them for up to $20 a pop, okay? So heroin, on the other hand, is very cheap. So if you go from if you can't get that medicine, these folks are gonna go out into the street and they're gonna buy heroin, and they're trying to, the best they can, extrapolate, okay, I used to take 40 milligrams of OxyContin twice a day and 10 milligrams of Percocet 3 times a day for breakthrough. What is that going to be in heroin? Well, I don't know, just give it to me, and then they're overdosing, all right? So that's one of the things that we're faced with right now. There is, one of the things you're going to hear about as well is something called the MED. And the MED stands for the morphine equivalent dose. So every medicine is compared to morphine. Morphine's old school, has been around for 100 years, right? So let's say a Percocet. Percocet compared to morphine might be 1.3 to 1, okay? Hydrocodone is a 1-to-1 comparison. Another medicine may be a little bit lower. And so what the regulatory bodies are saying is that if you don't have cancer, nobody should be on more than 90 morphine equivalent doses, or let's say 90 milligrams of morphine if you don't have cancer. That does not take into account that, let's say you've had 3 back surgeries and 2 knee surgeries and your hip's been replaced and you have all this pain. It's like, well, gosh, that's so insensitive. Well, the only thing I could tell you is to call your congressmen and your senators and try to explain to them, because they're just rushing down one path. They're not taking these other things into consideration, and they're gone headlong into completely moving the needle completely to the other side. As an example, at the VA hospital, probably about 6 to 8 weeks ago, they quit prescribing pain medicine altogether. So if you're a veteran with chronic pain, you walk in, hey, listen, I need my pain medicine. They said, sorry, we're out of the business. They're just not prescribing it anymore. I have workers' comp companies right now for workers' injuries. They're saying that if you're a brand new workers' comp patient, the first 30 days they will allow. After that, you have to be pre-authorized, and chances are you're not going to get it. They feel like, 2 weeks of pain medicine after a surgery, no matter how big, how small, that's it. And we're starting to see a lot of the private insurance companies, Blue Cross, United Healthcare, Cigna, and all the rest, following suit, to the point where I believe what's going to happen is they're going to stop paying for it. At CVS drugstore right now, if you're a chronic pain patient, as we state here, right, interrupting your daily lifestyle, and you say, hey, listen, I have to take 3 Percocet a day so that I can move, so I can walk. Well, if I give you 90 Percocets, let's say, CVS is going to make you come every 4 days. They're only going to release 4 days of medicine at a time. So here you are, back and forth to CVS every 4 days to get your medicine. So it's a problem, and everybody's trying to get their arms around this thing the best they can. But again, it's not taking everybody's conditions into consideration. And I agree with you. I fight for those that I can fight for, and the rest are unfortunately having to suffer a bit. Next, how long have you been having chronic pain? What are you doing to manage your pain, and how well has it been working? These are common questions that we ask in my business, and the insurance companies want to know, and so forth. And you can see this scale with the different, I guess you would call those emojis, right? That's the new thing. So, you know, if you can, even if you don't know, because we'll say, well, Mrs. Johnson, we'll grade your pain today. Is it 10 out of 10? And what I'll say is like, all right, well, 10 out of 10 is the worst pain you can imagine, and 0 is none. What's your pain today? And this is just another visual analog scale that we use sometimes to explain. All right, so chronic pain treatment options based on your needs. So obviously there are medications. You know, I try not to have that be first line for me because number one, you don't want the stigmas of, well, you just go to Dr. Parker and just tell him what's wrong. You go in, get a prescription and leave. Well, we're not that kind of organization, right? That stuff was running rampant in Florida and other places, and a lot of guys made a lot of money temporarily, and now they're wearing orange jumpsuits, if you know what I mean. But so medications are necessary in some cases, but we try to use some of these other modalities, if you will, to try not have that be our first line. Physical therapy. Physical therapy is a requirement by most of the private insurance companies right now in terms of they want to see, let's say you come to me and I say, oh, whoa, I see what the problem is right here. You need injections. And they say, hold on, doctor. Wait a second. Have they had physical therapy in the last 6 months for at least 6 weeks? And that's pretty much across the board. And they'll stop me in my tracks until that box has been checked. Now, one of the things that will help speed things along is if you attend therapy and it's hurting you worse, then they will count that and say, okay, well, that's fine. You attempted it now. Your pain management physician, whoever it may be, can move on with their recommendations. Reversible treatments, that's what I do. So epidurals, facet joint injections, the spinal cord stimulator, which we'll talk a little bit about later. Things of that nature are reversible treatments, right? Next, typically the first line of treatment, over-the-counter drugs, prescription drugs, and right now we'll try to do that with, and I'm sure some of you have had this experience where you've gotten non-steroidals. Okay, well, here's 800 Motrin and here's some Flexeril. You know, go home, wait a couple of days, and let's see how it goes, or they'll put you in therapy or something like that. Adjuvant medicines like antidepressants and anticonvulsants. Probably a lot of you in the room have heard of Neurontin. So Neurontin, when it was originally formulated, was a medicine created to help with seizures, but it didn't do it very well. But what they did find out, but quite by serendipity, is that it helped people who had nerve pain, tingling, fire ants sensation in your legs or hands, and all of a sudden they would get better. So Neurontin, as a result, which is considered a anticonvulsant, is a first-line drug, I would say, for neuropathy or neuropathic pain. Antidepressant Cymbalta, folks who have fibromyalgia, this is one of the treatments for it. Injections near the site of the pain, nerve blocks. That's something that I perform. We do one called a medial branch block, which is a temporary nerve block that we will do to try to prove where the pain is coming from. And if I can reduce your pain by about 70%, then X marks the spot, if you will, and we can start to make some more definitive treatment recommendations. And then obviously when you introduce something from the outside in, including getting your blood drawn or anything else, even though that doesn't happen, there's always a risk of infection. Long-term opiate use, again, you're going to hear more and more about it, guys. I mean, it's in the news every week, if not every day. And this is unfortunately one of the things we have to deal with. And granted, I have people you would never know, and they're from 40 to 80, who it's the only way they can get around. They've already done the injections. They've had surgery. They've tried everything. And this is the way they live. And it's okay as long as somebody who is well-versed in pain management is handling it so that the things don't get out of control, basically. All right. Physical therapy. Again, physical therapy is part of the continuum. The insurance company wants it to be first line, and I don't always agree with that. And I'm sure everybody in the room can think of times where maybe they were uncomfortable. And if somebody said, oh yeah, you need to go to physical therapy, I'm like, are you kidding me? I'm hurting like crazy. I can't imagine going to physical therapy. But this is, they are, in a lot of instances, first line in terms of what the insurance companies want to see you at least attempt before they allow some of the other things to proceed. What can they offer? Massage therapy, a lot of times that can be, you have therapeutic massage therapists who do a certain kind of massage for ailments and things of that nature. The therapist can use TENS units, transcutaneous electrical nerve stimulation, where you put, it's an energy source attached to pads, and it can be a bit of a pain reliever. More so it helps with increased tone or spasms, in my opinion. And then chiropractors. How many in the room love their chiropractor? Okay. And they are part of the continuum, I'll tell you that, okay? You know, in some instances, especially I had a lady today that I saw, and she said, well, you think I need to go to a chiropractor? And it had to do with her neck. And I said, you know, let me get an MRI on your neck first to know what we're dealing with before you have somebody start doing this. And it also let me know so that I can communicate with the chiropractor in terms of which direction I think we should go. And I'm all about being conservative, for sure. And I'm usually the last bastion between you and the surgeon. So I get it, trust me, I do. And then there are relaxation techniques like biofeedback and yoga. You don't find a lot of that down here because biofeedback in general is handled by psychologic staff. And in the Myrtle Beach area, the Grand Strand, so to speak, there's just not a lot of psych staff available other than to handle schizophrenia and really the severe kinds of things. But just to go in and be taught biofeedback and some of these things, you're going to find that in more metropolitan areas than you will here. And then counseling, so that falls kind of in the same area. All right, so this one therapy up here, the intrathecal pumps, that's kind of fallen out of favor. In the Northeast, it was really big, probably 15, 20 years ago, where you had these implantable morphine pumps, okay? So the onus would be taken away from you in terms of having to take a pill. They could, if you were a chronic pain patient and you required a certain amount of medicine, then they could place this pump that would just release a certain amount of morphine near the spinal cord, which would ostensibly take care of your pain. It was a go-to therapy, I should say, again, many years ago, but it had a lot of problems. A lot of times they would malfunction, the batteries would die, you would get infections, and so, or too much would be released in your system. And there were actually some people who got into trouble and up to and including expiring because of that. They had respiratory depression because it just, it malfunctioned and all this morphine spilled out into the system and they stopped breathing. So you don't see this as much anymore, although it still exists to some degree, but we're mostly, I don't know anybody who's putting in new pain pumps, so to speak. The spinal cord stimulator, however, that's the hotness right there, guys. That's 2017 and beyond. That's your Star Wars, okay? So the spinal cord stimulator is a device. It's been around a good 15 plus years, and like cell phones, it has morphed into better and better and better technology. There are three companies who basically tout and promote the spinal cord stimulator. There's Medtronics, who also does pacemakers and other technology. There's a company called St. Jude's, and there's Boston Scientific. Now, I happen to like Boston Scientific, and that's why they're here, because I'm a big advocate for Boston Scientific, because I feel like they have the most up-to-date intuitive technology that helps with chronic pain after surgery, or if you are a non-surgical patient, let's say, this is great technology that you can have placed in your back to kind of help you. The goal with the spinal cord stimulator as well is it may not eliminate your need completely to have to take pain medication, but it can certainly significantly reduce it. And in a lot of cases, it has changed people's lives and given them their life back and made them be more active as a result. The way this works is, and I'm just going to say this and not kind of snow you with a whole bunch of legal mumbo jumbo, but medical mumbo jumbo, I should say, but it works on something called the Melzack gate theory of pain. So essentially, what's happening is, the way I like to describe it is, you're creating an electrical dam. Okay, so we place leads in your spine. It's connected to an energy source, and it beams down on your spinal cord. And remember, I told you earlier that the spinal cord, right? That's the highway that every sensation travels up and down to tell the brain, hey, this hurts, this is hot, this is cold. So that energy source changes that message to something pleasant, okay? And there are a couple of different settings. I mean, most people will feel what they describe as kind of like being in a massage chair all day long. It's like, oh boy, this is good. It's kind of tingly and tickly and it's buzzing. And then there's another setting that we have called high frequency where you don't feel anything. Your pain is just either eliminated, significantly reduced, and that's it. Some people like the buzz, some don't. But this is great technology. We do a lot of this. There is usually a 5-day trial. Everything's on the outside. The leads are in you, but the battery source is on the outside. You have this neat remote control that looks like something on a video game, quite frankly. Don't let your grandkids get a hold of it. And you wear it for 5 days. Once that's done, then we remove the leads because we don't want you to get an infection, and we talk to you. So, okay, well, what did you think? Did it change your life? Did it not? Was it, was that buzzing sensation too much or not? And I would say we're running about a 75% what we call a trial to permanent ratio, whereby 75% of people who did the trial wanted to proceed to the permanent. Next, corrective surgery. In a lot of cases, once we've done all we can do, you've had every shot, you've been to therapy, you've had your chiropractor, sometimes surgery is the only option. If there's significant spinal stenosis, which simply means that your nerves are being pinched on either side of your body, either the left or right or both, and it's cutting the signal, right? So the whole purpose of nerve to muscle is, if my arm represents a muscle and this is nerve, this communication has to be open in order for the muscle to work. If I interfere with the message, then that muscle's gonna fail. Waking up first thing in the morning, you take those first few steps to go to the bathroom and you almost hit the ground. Like, what just happened, right? So you get a bit cool, so it could be muscles, but a lot of times it's because you have spinal stenosis. Sitting for prolonged periods causing pain and or weakness, standing too long, right? Man, I'm in the kitchen and I can't even stand up long enough to bake a cake. I gotta sit down. And then I got to get up, and I got to sit down, I got to get up. That's spinal stenosis. Discogenic pain, back pain that's as a result of your disc, typically hurts you more with bending. So what patients will complain of, they'll say, well, God, doc, my back hurts when I try to make my bed, right? You got to bend over, pull the covers. That hurts. Unloading the dishwasher, taking the trash bag out of the trash can, unloading the dryer. Anything that has you bend and then it hurts, that's typically your disc. You can have spinal stenosis though, and I want to correct some terms, from both things, right? So the disc, if this controller represents your spine, let's say this is the front and this is the back. So the disc then can, from front to back, compress your nerve, and then there's arthritis in the back of your spine that develops that can compress the nerve from back to front, and the poor little nerve is getting it in the middle. So the rub for me then is to figure out, all right, a lot of people have a lot of things. Where's the pain coming from? So anybody who's seen me before, I say, okay, what hurts you the most? Is it sit, stand, walk, or is it bending and lifting? Oh gosh, I've never really thought about it like that. Let me think. Or we'll go through the exercise in my office and we'll figure it out. But folks, let me just say to you, in medicine or in anything, your mechanic, the guy who fixes your air conditioner, you need to diagnose the problem first. And that is the thing I spend the most time on, because a lot of people have a lot of things. I have learned in my practice that there's the one thing of the 2 or 3 or 4 things you have that's really causing most of your angst. And that's what I try to drill down on, and that's allowed me to be successful, I think. Next, neuroablation. This is a procedure that we do a lot of, okay? You might have heard of rhizotomy or radiofrequency ablation or radiofrequency lesioning. What this is taking a needle, placing it in your back, and that needle is connected to a machine that gives off a radio wave. Like the microwave that we use to heat food and drink, right? When you put it in that machine, it just goes all over the place. And what it does is it causes the molecules to speed up in the food or the drink, and that causes a heating process. Well, the radio wave that we use, number one is we can direct the beam. So it's not all over the place, and it's safe for human tissue. So the same thing happens whereby it causes the nerve to heat internally, and that heating process short circuits the nerve. So it stops working. So remember, spinal cord is the highway, right? And out in the periphery, you have to have a message from here and it runs through the spinal cord and the brain gets it. So once again, we're altering some part of that process. And that's what the neuroablation does. We're cutting it off at the source and we're rendering that nerve ineffective. All right, so treatment objectives. We want to lessen your pain so that you can get back to life, which is what this slide is depicting. Chronic pain treatment options, once again, you have your medications, your physical therapy, your non-reversible, and your reversible. Reversible, so spinal cord stem, top of the list there. So this, for me, is the top of the mountain. If I've tried injections on you and they work, but now they don't. If I've done medicines and we've been to therapy and you've had surgery, this is top of the line technology in this business. Remember I told you about that video controller you don't want your grandkids to get? There it is. You can see how they can mistake it, you know. So that's the remote control. We pre-program that with algorithms. So we have people who, if they go fishing, they turn it on one setting. If they're going to the movies, they turn it on another setting. If they're going dancing with their honey, they turn it on another setting and so forth. That's a cordless charger. It does it via Bluetooth. You get near it and it charges you up. Your battery, that is, in about an hour, hour and a half. And there is the battery. That battery is about the size of a pacemaker battery. Like if you have friends or you yourselves have a pacemaker, it usually goes under the collarbone. We put that in the hip and we plug you in and off you go. All right, so how it works. So once again, there's a pain signal. Again, this is depicting kind of the highway, the spinal cord being the highway. The device sends electrical pulses to mask the pain signals or change the pain signal to something pleasant. Or, like I said, we can place it on a high frequency setting and you won't feel anything at all. It will just be a reduction in your pain or not. The pain signals now are masked as a smooth tingling sensation or a paresthesia. And it travels as it travels to the brain, does not cure the pain, but it manages it. Again, most of my patients who have spinal cord stimulators, they probably do still, I would say the majority still take medicines. It's just not as much as if they wouldn't have it. All right, so unique opportunities to test drive the stimulation. Again, this is a picture of the belt and sort of the power source that goes into it. That's where the wires are connected, and then further up, you can't see in this picture, will be the wires coming out of the skin, and I've actually placed those for you, and then we wrap you up and send you home. 5-day trial, and if you like it, as you can see here, we discuss it, you try it, next step, and if after the trial, we discuss whether you want to move forward or not, and if you do, then you end up with this. Once again, we have medications, physical therapy as an option, reversible treatment, which would be spinal cord stimulator, and then some of the injections that I do in the neck for cervical spinal stenosis or cervical radiculopathy. There are the cervical facet injections, cervical epidural steroid injections, in the low back, cervical epidural, lumbar epidural steroid injections, lumbar facet injections. The radiofrequency lesioning can be done both in the neck and in the low back. And by the way, that radiofrequency, if it's successful, it can get you about 1 or 2 years of relief. So it's a pretty good treatment. I've had people throw their walkers down, not because they were mad, but they didn't need them anymore. And they're gone back to playing golf again. Guys who are like, I never thought I'd play again, get rid of canes and everything. It's a great, great treatment. All right, so again, when you come to someone who does what I do in pain management, you know, we obviously discuss all the different treatment options for you. And again, I don't want you to have surgery if you don't need it. Okay, so when you come to a pain management physician, I think most of us feel this way. Our job is to try to get you back to life, keep you mobile, keep you active without having to undergo the ultimate, which would be, of course, surgery.